Bismillahirrahmanirrahim. Assalamu alaikum everyone and welcome to Pakistan Cardiac Super League Season 2 presented to you by Pakistan Cardiac Society and powered by Wilson's Pharmaceuticals. Once again with a short break, we are back with a crucial game from the Super 6 stage, and it is going to be between NSAVD Kings from Karachi and PIC Hawks from Lahore. I'm saying this crucial because it is going to decide the fate of these two teams, that who's going to book their place for the final at Cardiacon in November of next month. And with this, I would like to welcome to the senior faculty members who have joined us for this match. We have with us the match umpire, Professor Mohammad Ishaq Saab, and we have also with us Professor Abdul Hamid Siddiqui Saab. He is also going to be the umpire of today's match. And from the Governing Council of Pakistan Cardiac Super League, we have with us the General Secretary of Pakistan Cardiac Society, Professor Fawad Farooq Saab. And shortly, some other panelists will also be joining us, and they will be introduced during the match. And last but not the least, I'm going to introduce Dr. Hamza Ghori Saab. He is the moderator of today's match. And without a further ado, I would now extend the mic towards Dr. Hamza Ghori Saab to please start the formal proceeding of today's match. So over to Dr. Hamza Saab.
Thank you very much, Hamza. So I welcome you all to the second season of Pakistan Cardiac Super League, which is brought in collaboration with Pakistan Cardiac Society and Wilson's Pharmaceutical. We now know that we are into the Super 6 stages, the fifth match, and an extremely important match. It's quite crucial for both the teams. And one of the teams definitely has the potential to qualify and get into the finals. Let's see what happens. Well, I would now like to take the opportunity of introducing and welcoming our esteemed panel. As we know, Professor Fawad Farooq Saab is here, and as more panelists they join us, we'll have the introductions. But at the same time, it's the umpires who are extremely important for us. So I would like to welcome Professor Ishaq Saab. He is the first umpire, and our second umpire for the day is Professor Abdul Hamid Siddiqui. Welcome, sir. So, the two teams that are up against each other, NICVD Kings versus PIC Hawks. It's a crucial game, and I'm hoping that it's going to be an extremely high-scoring game with a lot of nail-biting going on. All right, so we now move towards the two teams. So can we have PIC Hawks?
Assalamu alaikum, sir. I'm Dr. Abdul Rahman, postgraduate resident at Punjab Institute of Cardiology. I would like to introduce my team. On my left is Dr. Zarduna, on my right Dr. Shahid and Dr. Usman. All of us are postgraduate resident in the third, fourth and final year. Thank you.
Thank you and best of luck for the game. NICVD Kings. Introduction, please.
Assalamu alaikum. I'm Dr. Kainat Naseem, the captain of team NICVD Kings. On my right we have Dr. Shahir, and on my left we have Dr. Sumaira and Dr. Shidba. Thank you.
Thank you and best of luck to you as well. And I would also request everyone to keep their mics muted because we can still hear some crosstalk. So we are now moving towards the all-important coin toss. So can we have the electronic coin? Yes. So randomly, I will ask NICVD Kings, what do you want to call? Heads or tails?
Heads. Heads, sir.
They want heads. Roll the coin. And it's heads. All right. So again, we've got two questions for you. Do you want to throw the questions or you want to take the questions?
Sir, we want to take the questions first.
Okay. So NICVD Kings have won the toss. They want to take the questions first. And the second question is, you've got to...
Okay.
ये तो उन्होंने वो सारा हमारे वाला सिनेरियो है heads take question select
Okay, so we want to go with case A.
All right, so they've taken their time, but they've decided to go with case A. The news from the center is that NICVD Kings have won the toss. They want to take the questions, and they've taken scenario A. All right. So, okay, PIC Hawks, I think we can hear you guys in the background. I will request you to please mute the mic. All right. Okay, so can we have the question and the scenario here? Can we have the scenario, please? Good. And I will request Hawks to please go ahead.
Case A. A 62-year-old male patient presents to your clinic with a history of hypertension. Despite being on a triple drug regime consisting of amlodipine 10 mg per day, lisinopril 40 mg per day, and hydrochlorothiazide 25 mg per day, his blood pressure remains elevated at 180/90. He has a history of diabetes, hyperlipidemia, and TIA. His lifestyle is sedentary, and he consumes a high sodium diet.
All right, so NICVD Kings, you have a couple of seconds to gather.
Okay, so 62 male है, hypertension है, amlodipine 10, 40 mg, 6 hydrochlorothiazide ले रहे हैं, BP इनका भी elevated range में, diabetic,
So,
lipids,
are you ready?
which उन्होंने address
Are
नहीं
you
किया.
ready, Kings?
Yes, sir.
Can we have
Yes,
the
sir.
first question on the screen, please? Read the question, Hawks.
What defines resistant hypertension? Option A, blood pressure more than 140/90 mm of mercury despite 3 drugs. Option B, blood pressure more than 160/90 mm of mercury despite 3 drugs. Option C, blood pressure more than 140/90 despite 4 drugs. And option D, blood pressure more than 160/90 despite 2 drugs, including diuretics and lifestyle modification. And option E, blood pressure more than 180/100 regardless of treatment.
And 60 seconds on your screen. So I will request NICVD Kings to keep their mics unmuted. We would like to hear your crosstalk.
देखो 140/90 से ऊपर on 3 drugs, तो ये elevated ही है. हाँ, 3 drugs से.
अब 3 ड्रग्स कौन सी हैं ये नहीं
2
पता
drugs की
है।
बात.
20 seconds.
तो मेरे कहने ऑप्शन बी, ऑप्शन ए क्या कौन सी है?
मुझे भी A लग रहा है. 3 drugs be elevated. 140/90 is elevated.
10 seconds. Come on.
Go with A.
We would like to go with option A.
All right. So very carefully, they have decided that they want to go with option A. Okay, A alpha. Lock option A. Yes. Great start. That's a 6. Over long on, I would say. What a good shot. What a good start. That's what we need. We need a high scoring game today. A good fight. Well, moving to question number 2. Read it, please.
What is the next step in managing this patient's resistant hypertension? Option A, add beta blocker. Option B, add spironolactone. Option C, increase diuretic dose. Option D, switch to alternative antihypertensive class. And option E, refer for renal denervation therapy.
And your timer starts now. 60 seconds. Again, I will request everyone to start talking once the question has been read.
थाइज़ाइड
ऑलरेडी
बढ़
25 ले रहा है.
हाँ, लेकिन इसको बढ़ सकता है, लेकिन इसको हम लोग ऐड ऑन करेंगे।
हाँ, ऐड ऑन करेंगे ना.
Fourth drug add on therapy.
हाँ,
हाँ.
ऐड ऑन करेंगे, जो कि मेरे ख्याल में वो
स्पाइरोलेक्टोन बी लगता है.
हाँ. मुझे भी यही लग रहा है.
या बीटा ब्लॉकर एंड स्पाइरोलेक्टोन बोथ हमारे पास इसके हम लोग पोटेशियम को देखते हैं, पोटेशियम नहीं किया तो हमारा स्पाइरोलेक्टोन इससे ऊपर है हमारे पास बीटा ब्लॉकर से, तो वो चीज पर
लेकिन लाइफस्टाइल मॉडिफिकेशन अभी तक नहीं आया हमारे पास.
20 seconds.
Okay. So we would like to go with option B, add spironolactone.
Are you sure? You want me to lock option B? Beta.
C.
Come on.
Yes.
Okay, so they want.
हम स्लाइड नहीं देख रहे यार, हम प्रेजेंटेशन नहीं देख रहे.
Okay, sir. Sir, have you pinned yourself, sir?
I got it now.
Okay, that's great. All right, so they have chosen option B. Lock option B, please. Oh, another one. That's another 6. This time over long off. Very good. Very well done. Well played. Can you do a hat trick of 6s? Let's see. Question number 3 on your screen.
Patient's BP remains uncontrolled 170 by 95 after adding spironolactone. What is the next step? Option A, add clonidine. Option B, add hydralazine. Option C, increase diuretic dose. Option D, switch to direct renin inhibitor. Option E, consider renal denervation therapy.
And timer starts now.
या बी है हाइड्रोलाइजिन है क्योंकि हमें आर्टरी डायलिसिस तो करने हैं शायद
हाइड्रोजन का मैंने जिक्र नहीं किया।
हाइड्रोलाइजिन नहीं है, हाइड्रोलाइजिन नहीं है, ये मैंने हाइपरटेंसिव
बाकी ऑप्शन नहीं है
डायरेक्ट रेनिन इनहिबिटर नहीं
बीटा ब्लॉकर हमारे पास होता है या एक्स ब्लॉकर होता है अब
रीनल डिनर्वेशन थेरेपी पे कब जाएंगे?
जब वो सारे ड्रग्स खत्म हो जाएंगे मतलब बाकी तो क्योंकि किसी भी क्लासिफिकेशन में ये मेंशन
20 seconds.
हां
अल्फा ए
हां
We would like to go with option A, add clonidine.
All right. A alpha. You want me to lock it?
Yes, sir.
Okay. Lock A alpha. Oh, that's the first miss. An outswinger whizzing past the bat, the outer edge. Well. It was hydralazine. Okay. Still have a lot of questions to go. Question number 4 on your screen.
What is the most common cause of pseudo-resistant hypertension? Option A, medication non-adherence. Option B, medication under-treatment. Option C, white coat effect. Option D, inaccurate BP measurement. And option E, high sodium intake.
And timer starts now.
मेरे
Most
हिसाब
common cause of pseudo-resistant
और
hypertension.
हमारे पास
इस पेशेंट में नहीं पूछ रहे वैसे
Most common also.
ऑब्वियसली हर पॉपुलेशन में नॉन अटेंडेंस इज द मोस्ट कॉमन नॉन कंप्लायंस
एक्सक्लूजन में जाओ ना, देखो
हां ना
एक्सक्लूजन में जाओ। मेडिकेशन हम बढ़ाते ही जा रहे हैं,
हाँ।
बी तो नहीं होगा, सी भी नहीं है, डी भी नहीं लग रहा और ई भी नहीं है।
फोर ड्रग्स लिख सके 5 दे चुके हैं हाइड्रोलाइजिन तक दे चुके हैं
Okay, 15 seconds. Come on.
ऑप्शन
10.
Option A, medication non-adherence.
Okay, so you want to go with A alpha, medication non-adherence.
सूडो रेजिस्टेंस है
You want me to lock it? Yes.
सूडो
Option A alpha. Lock the option. Oh, no. That's the second miss. So the right answer was medication under treatment, which was option B. All right. With this, we move to question number 5.
If this patient's BP remains uncontrolled 160 by 90 despite optimal quadruple therapy, what non-pharmacological therapy can be the next step? Option A, consider renal denervation therapy. Option B, add carotid baroreceptor stimulation. Option C, switch to alternative antihypertensive classes. Option D, increase diuretic dose. And option E, referred for surgical sympathomiectomy.
60 seconds on your screen.
मैंने renal denervation पढ़ा है।
पढ़ा
Renal denervation को पढ़ा है, surgical sympathomiectomy
नहीं अगर इसे शॉर्टली मुझे याद मैंने
एग्जैक्ट स्टेप वाइज इसकी अप्रोच है, लेकिन ये है कि इसका लास्ट स्टेप renal denervation।
लास्ट देखो सिंपैथेटिक
इसमें देखो ना, डी आप माइनस कर
इस
दो।
पेशेंट की बात कर रहे हैं, अगर लास्ट रीनल है तो उससे पहले सिंपैथेक्टमी नहीं आएगी।
यार बट सिंपैथेक्टमी
उससे पहले नहीं आता सर।
बट सिंपैथेक्टमी जो है अल्टीमेटली वो जो रियल डिनर्वेशन भी वैसे काम करेगा
लेकिन जो एग्जैक्ट जो मेंशन वो सर्जिकल नहीं है, renal denervation।
रियल डिविजन
20 seconds.
बाकी नहीं है मेरे से।
डायूरेटिक डोज का ऑप्शन नहीं है।
10 seconds. Come on. 7, 5.
Consider A. We would like to go with option A.
Okay, so just at the last moment, they are saying A alpha. They want to lock option A alpha. Lock it. Yes. So it was a cross seam delivery. It could have gone either ways. But I think just because they had read renal denervation, different trials coming, like simplicity series of trials, I think well done, well played, very well done. So they are back on track. So a score of 18 after 5 questions. 5 more to go. You're playing it sensibly, discussing things, but you need to give the correct answers, and we are hoping for it, for a high score. Question number 6 on your screen.
What is
Expected BP reduction after renal denervation therapy. Option A 5 to 10 millimeter of mercury. Option B 10 millimeter of mercury. Option C 15 to 20. Option D 20 to 25, and option E 25 to 30 millimeter of mercury.
And 60 seconds on your screen. She reads the questions very fast. Very good. She's on it.
ये भी तो नहीं
ज़्यादा
ये भी तो नहीं लग रहा ये भी का तो फायदा है
यार
ए का कोई अगर हम कर ए के लिए अगर हम अचीव कर रहे हैं तो देयर इज नो कट सी और डी
सी और डी क्योंकि 170 है ना, अब कम से कम एटलीस्ट 30 कम करें 140 तक पहुंचेगी।
20 seconds. It's a rising delivery. Can you hook it well? Come on, 10 seconds. 7. Option 4.
C.
Okay, so just at the last moment, I heard C. C Charlie. Do the umpires agree with me?
No. Umpires.
Option C. All right. So we are going to lock C Charlie. Lock it, please. Oh no! The wrong answer, but somebody said B. I don't know who that was, but I heard it. Anyhow, you were very close. All right. 4 more questions to go. Be wise, be smart. Question number 7 on your screen.
Which of the following is a potential complication of renal denervation therapy? Option A hypertension, option B renal artery stenosis, option C nephropathy, option D atrial fibrillation, and option E refractory hypertension.
And the timer starts now. 60 seconds.
अच्छा हाइपरटेंशन हो सकता है, कंसीडर किया जा सकता है, लेकिन डीनर्वेशन से आर्टरी स्टेनोसिस का कनेक्शन है, हम नर्व्स इन्फॉर्म कर रहे हैं।
ए से बी हटा दो
हाइपरटेंशन
भी अंडरस्टैंडेबल, मतलब कोई लिंक नहीं है।
बी और डी इसलिए माइनस कर दो ना।
हाँ,
ठीक है।
नेफ्रोपैथी एंड रिफ्रैक्टरी हाइपरटेंशन।
रिफ्रैक्टरी हाइपरटेंशन भी हो सकता है,
क्योंकि ये भी तो हो सकता है ना कि उसको भी और वजह उसकी रीनल
वो तो हम रूल आउट करके करेंगे ना फिर।
जो भी वजह थी, अभी कॉम्प्लिकेशन पूछ रहा है आपसे, सिंपल
हाइपरटेंशन हो सकता है ना, क्योंकि हम बिना डीनर्वेशन
20 seconds.
खत्म हो जाएगा।
लेकिन देखो एक
15. Come on.
ये हम
जो भी हम कर रहे हैं हम रिस्पॉन्स कम कर रहे हैं।
9, 7. Come on.
जल्दी
Answer.
E sir।
Okay, they say E epsilon. E, refractory hypertension. All right, lock E epsilon. No, that's the wrong answer. All right. So, NICVD Kings.
Hamza, slightly change.
लास्ट 5 सेकंड्स तक फाइनल कर लो।
Sir,
Hamza, I can't see the latest slide.
so you can't see the slide? Okay. Sir, have you pinned Cardiac Super League? Actually, sir, there is some internet issue as well. We can't hear you properly. Your voice is breaking.
Can you hear me now?
Yes, we can hear you now.
Can you hear me now?
Yes, yes, sir.
Now, the thing is, these slides are not being shared with me regularly. So, I'm a bit lost.
So, the technical team, can you help us with this? What's going on?
वो तो क्वेश्चन 2 पे स्टक हुआ हो.
So, is there any way where Professor Ishaq Saab can pin himself again to see the slides, technical team?
What question we are doing now?
Okay, sir, we are on question number 7, which has been wrongly answered. Question number 7.
Inshallah.
So, are you there, sir? Have you seen it?
Yeah, I'm there, very much there, but please slide change करें.
Okay, technical team.
What question we are at the moment?
7. We have done question 7. We will now be moving to 8. Question number 8.
Okay, so I would like to see 8.
Okay, so can we have question number 8 on the screen, please? Read the question.
What is the recommended antihypertensive medication adjustment after renal denervation therapy? Option A, continue current medication unchanged. Option B, reduce medication dose by 50%. Option C, discontinue diuretics. Option D, add beta blockers. And option E, switch to alternative medication classes.
And timer starts now.
देखो उसके जो बीपी था ना वो 15% कम हो रहा है, रिड्यूस हो रहा है. तो अगर हम ऑलरेडी मतलब अगर 150 का ब्लड प्रेशर है उसमें कम हो गया 1% कर रिड्यूस कर देंगे. नहीं ना.
और जब भी अब तो रीनल आर्टरीसिनोसिस हो रही है, बड़ी कॉम्प्लिकेशन, यानी कि हमारे पास
हमें कुछ कर देना
बीटा ब्लॉकर हो सकता है.
कंटिन्यू करंट मेडिकेशन अनचेंज ही छोड़ दो.
इस पेशेंट में नहीं वो जब कह रहा है कि रिकमेंडेशन क्या होगी
कोई नर्स रखी है कि वो
नहीं करेंगे बीटा ब्लॉकर.
देख जाए
20 seconds.
क्योंकि रीनल आर्टरीसिनोसिस को प्रिवेंट तो करना है ना.
अगर वो कैसे प्रिवेंट तो ना अगर वो बीटा ब्लॉकर कैसे
आप प्रेशर कम करोगे.
बताओ
10 seconds, come on.
A.
You want me to lock option A, alpha?
Yes, sir.
Okay.
Yes, sir.
They want us to lock A, alpha. Lock it, please. Oh, yes. A, and you got it right. And we needed this to have a good score. All right. Hawks are smiling as well. I can see them. Good answer. Well done. So, Sir Ishaq, you can see the slides now?
Yes, sir.
Okay, I think we've lost Ishaq Saab. Technical issues, I think internet issues going on. But with this, we will now move to question number 9, the second last question of the innings. Go ahead, please.
What is the recommended follow-up after renal denervation therapy? Option A, 1 month. Option B, 3 months. Option C, 6 months. Option D, 9 months. And option E, 12 months.
All right, 60 seconds.
renal denervation के सारे.
Six months जब हम हाँ बिल्कुल.
तो 3 करना 1 करना.
I think we need to follow early.
बट डी की बात.
Whether effective है या नहीं हमने जो किया
Approaching 20 seconds.
Yes, we should go with option D.
नहीं यार इसको नहीं
इसके हिसाब
मुझे लेट लग रहा है 3 months.
3 months नहीं लग रहा है. 1 month.
Okay.
10
So
seconds.
we would like to go with option A, 1 month.
Okay, it seems as if you really like option A. Option A, alpha, 1 month. Okay, Hawks are smiling again. Is it correct or not? Let's see. Lock A, alpha. Oh! No! 3 months was the right answer. Well. So it's getting interesting because I think you want to be in that zone of 30 plus. And we just have one more question to go, the last question of the innings. I think an extremely crucial question. You have to play it smartly. It's not going to be easy, but I'm sure the Kings can do it. All right. Can we have the last question of the innings? Question number 10.
Which of the following trials demonstrated the efficacy of renal denervation therapy? Option A, simplicity hypertension 1, option B, simplicity hypertension 2, hypertension 3, option D, reach, and option E, spiral hypertension on.
All right, timer starts now, and I'm smiling.
Moderator.
It's still a tricky one, I tell you. It's not that simple. Hawks?
है सिंपलिसिटी ट्रायल है।
अब दूसरी चीज क्योंकि डिनरेशन ऑब्वियसली तो पहले जमाने में नहीं होगी, पहले 1 हो चुका होगा, उसके बाद 2 आया होगा,
तो सिंपलिसिटी फॉलो है, सिंपलिसिटी ट्रायल ये
2 के है ना।
ठीक है
यार
ओके करें
यार एक घंटे में सोचो भी टाइम है, अभी टाइम है,
इतना भी नहीं है।
तो बोलने बंद कर।
सो आई थिंक इसका कर ले
अभी बी का ट्रायल की जरूरत क्या पड़ी होगी?
ऑप्शन बी सिंपलिसिटी हाइपरटेंशन 2
Come on. Which one?
B.
Are you sure?
B, sir.
You want to go with simplicity hypertension 2 trial? Are you absolutely sure?
Yes, sir.
So you've already chosen option B, beta. Okay, let's see. Are we hitting 30 runs or not? Lock B, beta. Oh, yes. That's very well done, well played. So I still think it's a reasonable score, 30. But I tell you, this is beatable. This is doable. Hawks, it's not a very high scoring game. And I think I just wanted to ask the Hawks, can you do it? Can I have Hawks on the screen? Can you beat the score?
Inshallah.
Okay, so best of luck to both the teams. So that's the news in the first innings.
Hamza?
Sir. Yes, sir.
Good score. The question was very, very relevant, very practical, day-to-day problem. And I think score is reasonable. Could have been better. But थोड़ा सा बीच में मुझे interruption हुआ because of that problem.
Sir.
But I think I would like to say that so far so good. Let's see what the other team does.
Right, sir. Thank you very much for the input. It's still open. And I would also like to take Professor Abdul Hamid Siddiqui. Saab, sir, is he there? So I think I'm now going to move on to Professor Fawad Farooq. Sir.
I think an exciting match ahead because a borderline score. So let's see, I think, without wasting any time, just jump on to the second inning.
Extremely
Usually
important.
Hamza is, I think, always in the scrubs. We have Saturday a bit off, but today we are busy. But Hamza is always busy.
Interestingly, sir, it's cat on the go for us. So that's how it goes.
Oh, good. Just go ahead.
Thank you, sir. And so we still don't have Professor Abdul Hamid Siddiqui, I think. So let's move on to the second innings now. All right. Can we have the scenario on the screen? All right.
Okay, so should I read it?
Yes, read the question. Read the scenario rather.
Okay, sir. So the case is a 42-year-old woman who presented to urgent care with 2 weeks of worsening dyspnea on exertion, fatigue, and occasional palpitations. She reported a flu-like illness months prior that resolved with conservative management. After several days, there is history of pleuritic chest discomfort, non-productive cough, fever, and occasional chills. Her only medication was an oral contraceptive. Her vital signs were heart rate of 108, blood pressure of 102 by 76 millimeter of mercury, respiration 16 per minute, and peripheral capillary oxygen saturation of 97% on room air. On physical examination, she was in no apparent distress. Jugular venous pressure was 10 centimeter of water. There were no murmurs and the lungs were clear. The extremities were warm with stress pedal edema.
All right, so I'm just going to give the Hawks a couple of seconds to gather themselves and let me know when you are ready.
42 years old, postmenopausal woman.
Hawks, are you ready?
Okay, sir.
Okay,
Yes, sir.
let's bring the first question on the screen.
So, which of the following is not the diagnostic criteria for acute pericarditis? Widespread ST elevations or PR depressions on ECG. B. Chest pain. C. Fever of 38 degree, more than 38 degree Fahrenheit. D. Pericardial rub. E. New or worsening pericardial effusion.
And 60 seconds are on your screen.
Fever, chest pain भी होती है, हाँ, pericardial rub, new or worsening pericardial effusion ये भी है, हाँ, fever, C, C है, widespread ST elevation भी होगी, chest pain भी होगी, pericardial rub भी होगी, new or worsening pericardial effusion, C. So we will go with the fever more than 38 degree Fahrenheit, C.
Are you sure? So you have come down the wicket trying to hit it for a 6. Should I lock C Charlie? Are you sure?
Yes, sir.
Okay, they are sure. Lock C Charlie. And yes, it's a 6. Well done. Great start. Very well done. All right, that's the kind of start we need. Question number 2 on the screen.
An electrocardiogram revealed sinus tachycardia and low precordial voltage. The echocardiogram would most likely demonstrate which of the following? A. Inferior vena cava plethora. B. Right ventricular dilatation. C. Severe tricuspid regurgitation. D. McConnell sign. E. Biatrial enlargement.
All right, timer starts now.
So we will go with the A, inferior vena cava plethora.
Are you sure? This time you've really come down the wicket.
Yes, sir.
Option A, alpha.
Yes,
you want me to lock it?
Yes. Yes,
okay,
sir.
Ishaq Saab won't be happy, but you are confident, you are sure. Lock A, alpha. Oh yes, another 6. Overcovers this time. Very well played. Confident answer. They mean business. All right.
हमजा अगर आपको आंसर पता भी हो तो थोड़ा सा टाइम लेना चाहिए, एकदम जंप नहीं करना चाहिए.
I knew it, sir.
Think that there is some leakage.
Very right. I think you've got a strong point, but they seem to be ready for it. And but Ishaq Saab, I think these are some pearls of wisdom for everyone. So do pay a lot of heed to it. All right. Can you make a hat trick? Question number 3 on your screen.
Echocardiography reveals large circumferential pericardial effusion. Which of the following echo parameter is not a sign of tamponade? A. Right atrial notching in early diastole. B. Right ventricular collapse in early diastole. C. Abnormal septal motion. D. Left atrial ventricular collapse. E. Diminished respiratory variation of tricuspid and mitral inflow velocities.
Timer starts now. 60 seconds.
अच्छा उसमें ना exaggerated होता है, E होता है इसका, जो E और A वेव होती है वो exaggerated होती हैं, ठीक है?
Slide change on the screen.
Sir, your voice again is breaking.
I can't see the slide.
Okay, sir, can you move
I can't see the slide.
Sir, can you shift the slide on the phone with your finger? Can you move it? Do you see it? 20 seconds.
Sir, we will go with the option E, diminished respiratory variation of tricuspid and mitral inflow velocities.
Are you sure you want me to lock it? E epsilon?
Yes, sir.
Okay, lock E epsilon. Oh yes! Surely. It's a hat trick. They've put 3 correct answers, 3 sixes on 3 questions. Well, they're playing pretty well at the moment. Before I move to the next question, Sir Ishaq, are you there? Do we have Ishaq Saab? Okay, so I think he's having some technical connection related issues. With this, we'll move to question number 4.
So patient undergoes closed pericardiocentesis via sub-xiphoid approach. 500 ml of straw-colored fluid is drained, but patient develops pericardial decompression syndrome. Which of the following is the most characteristic feature of pericardial decompensated compression syndrome? A. Reaccumulation of pericardial fluid. B. Acute heart failure. C. Paradoxical hypertension after pericardial fluid removal. D. Bradycardia following pericardiocentesis. E. Sudden onset of atrial fibrillation.
60 seconds on your screen. All right. Is this a flipper or a googly?
Reaccumulation भी हो जाती है इसमें. Most characteristic feature of reaccumulation, paradoxical hypertension. B नहीं होता. Structural sudden onset. Maybe. A या B करना.
20 seconds.
Acute heart failure भी हो सकता है. A करना.
10 seconds.
Acute heart failure, sir. Answer B.
You want to go with option B, beta, acute heart failure?
Yes, sir.
Okay, this time they've taken their time. I think they are not too sure. Option B, beta, lock it. Oh yes, again, 4 in a row. Even when they were not sure, they got it right. So very well played. Well done, team. So PIC Hawks, they are on course. But still, I've seen funny things. Anyhow, moving to question number 5 on your screen.
Okay, so fluid analysis shows the following. Appearance is straw-colored, white blood cells 3000, protein 5.2 gram per deciliter, glucose 40 mg per dl, adenosine deaminase is 100 unit per liter. Which of the following is the most appropriate next step to confirm the diagnosis of tuberculous pericardial effusion? A. Repeat pericardiocentesis and send fluid for Mycobacterium tuberculosis culture. B. Initiate empiric anti-tuberculous therapy. C. Perform pericardial biopsy for rehistopathology and culture. D. Obtain a chest CT scan to look for evidence of pulmonary TB. E. Require interferon gamma release assay to confirm latent tuberculosis infection.
And your 60 seconds start now.
See, मुझे भी सही लग रहा है. Appropriate next step.
Biopsy
to confirm. नहीं, उसमें next step पूछ रहा है ना, most accurate नहीं पूछ रहा ना. Repeat
नहीं और सिर्फ मैंने उसके
biopsy लग रहा है.
pericardial biopsy कौन?
इग्रा जो है इंटरफेरॉन गामा.
20 seconds.
biopsy तो pericardial biopsy तो कभी पढ़ी
नहीं होती.
Come on, 10 seconds.
Option C, sir. Pericardial biopsy for histopathology and culture.
Which option? Say it again.
C.
Option C, Charlie. All right. They want us to lock option C, Charlie. Lock it. Oh! Another one. That's 5 in a row. Brilliant. Absolutely brilliant. And with this, we have a tie now. And you've got still 5 more questions to go. Well.
Exciting, Hamza.
Sir, great stuff. I think they've played it very well. They still have 5 more questions to go. And what a great game. All right. Can we have question number 6 on the screen?
So the workup for pericardial effusion revealed tuberculous pericardial effusion. She was started on anti-TB therapy and later discharged. She returns after 3 months with increased dyspnea on exertion. ECG is unremarkable and echo shows a small persistent pericardial effusion with tubular shaped LV with normal function. Along with diastolic bounce as well as plethoric inferior vena cava and respirophasic transmitral and tricuspid variation. Her hemodynamic tracing is shown below. The diagnosis is A. Cardiac tamponade, B. Restrictive cardiomyopathy, C. Recurrent tuberculous pericarditis, E. Effusive constrictive pericarditis, E. Severe mitral regurgitation.
And the timer starts now.
Sir, we can't see the hemodynamic tracing. Sir, hemodynamic tracing is not visible. Hello? Sir, we can't see the hemodynamic tracing. Sir, I can't hear you.
You can't hear me? Can you hear me now?
Yes, sir, I can hear you.
You can hear me now?
I can hear you now, but we can't see the hemodynamic tracing.
Okay, so hemodynamic tracing. Please show them the tracing. Okay, so they are working on it. You'll have it soon. You'll have it.
Small persistent pericardial. Small effusive, तो ये effusive constrictive होगा.
Okay, can you see the tracing now?
Yes, sir, we can see it now.
Okay, so they have the tracing.
LV
Okay,
और
the
RV
timer is going to start now.
diastolic equalization है LV RV की. ये 12 और 11 तकरीबन सेम है. 89, 39 and ventricular interdependence भी.
Okay, 16 seconds, 15, come on.
We will go with the D, effusive constrictive pericarditis.
Are you sure you want me to log D delta?
Yes, sir.
Okay, lock D delta. Oh, wow, that's brilliant, absolutely brilliant. I thought this one would be difficult for you guys. I thought we had wasted a few seconds in this, but you've come out all guns blazing. You got this one right as well. Very, very well done. And with this, we know that you have taken over. You've scored more. Your score is 36 on 6 questions. So you are still in the hunt for that record. You can still do it. 4 more questions to go. Can you get them all right? Can you create history? Let's see. So still a lot is at stake, and NICVD Kings, I think they will also stay interested, all for all the more reason. Can we have question number 7 on the screen?
Okay, so the question number 7 is, in effusive constrictive pericarditis, which of the following best describes the underlying hemodynamic mechanism that persists after pericardiocentesis? A. Increased LV compliance due to relief of external pressure. B. Transient decrease in right atrial pressure immediately following fluid drainage. C. Unchanged ventricular interdependence despite pericardial fluid removal. D. Normalization of pericardial pressure with continued restriction of ventricular filling. E. Increased stroke volume and cardiac output following pericardial fluid drainage.
The timer starts now.
Unchanged ventricular interdependence despite pericardial fluid removal.
Option C, unchanged ventricular interdependence despite pericardial fluid removal.
Okay, you want me to lock C, Charlie?
Yes, sir.
Are you sure?
Yeah, sort of.
So they are sort of sure. Can they guess it right with sort of sure? Lock C Charlie. Oh yes, they can. Wow, this is too good. 7 questions in a row. Very well done. I think they are going for creating history. 10 on 10. We haven't had it this season. We would love to have it. Okay. Moving to question number 8.
Which of the following would be the most appropriate management step? A. Initiate steroid along with anti-TB therapy and discharge on per oral diuretics. B. Admit on IV diuretics. Continue anti-TB therapy with plan to do CMR on urgent basis. C. Start aspirin and colchicine and repeat echo in 3 months. D. Withhold anti-TB therapy and plan to do myocardial biopsy to find alternative cause. E. Refer for pericardiectomy.
Start the timer.
Pericardiectomy करनी है. हाँ?
Pericardiectomy.
Hmm?
Pericardiectomy.
Exclusive constructive है ना, recurrent करनी है.
Different होती है steroid. E.
Pericardiectomy. चलो E बोलो.
Sir, option E, refer for pericardiectomy.
Which one?
Option E, refer for pericardiectomy.
Option E, refer for pericardiectomy. All right. E epsilon. They want us to lock E epsilon. Let's see. Lock it. Oh no! Oh, I was really rooting for you guys. I wanted 10 on 10, but never mind. You've done really well so far. That's the first blemish, first miss, but it doesn't matter. Okay. Moving to the second last question of this innings. Question number 9.
Patient remains symptomatic despite on medical therapy and was planned for pericardiectomy. Which of the following is the most common early post-operative complication of pericardiectomy? A. Pulmonary embolism. B. Recurrent pericardial effusion. C. Left ventricular free wall rupture. D. Low cardiac output syndrome. E. Atrial fibrillation.
And timer starts now.
Low. सही है. बोलो. नहीं. Low.
Option D, low cardiac output syndrome.
So, you want me to lock option D?
Yes, sir.
Delta. Are you sure? D delta?
Ji, sir.
All right, they are sure. D delta. Lock option D. Yes, they sure are. Great answer and great play. Well done, very well done indeed. With this, we now move to the last question of the match today. We already know that one team has won PIC Hawks with a score of 48 so far. Can they match the highest total of this season? Moving to question number 10. Hawks focus.
Okay,
One more question
so
to go.
which of the following statements about hemodynamic findings in constrictive pericarditis versus restrictive cardiomyopathy is correct? A. Diastolic dip and plateau pattern is present in the right ventricular waveform. B. Concordance of LV and RV systolic pressure during respiration is typical. I cannot see the complete option, sir.
Yes.
Okay, so technical team, can you adjust the slide? Because they can't see the extreme right edge.
Yes, sir.
Okay, just hold on. They're working on it.
D answer.
So can you adjust it?
उधर से नहीं है लेकिन इसका ऑप्शन
Okay, so I think they are unable to show it right now. It says option B is concordance of left ventricular and right systolic pressure during respiration is typical of constrictive pericarditis.
Option C, constrictive. Okay.
Okay, so you can continue reading it. In constrictive pericarditis, that's option C. In constrictive pericarditis, the ratio of RV systolic pressure to RV end diastolic pressure is usually greater than 3:1. Usually greater than 3:1. And option D is an RV systolic pressure greater than 50 millimeter of mercury is more consistent with restrictive cardiomyopathy than the constrictive pericarditis. Option E is none of the above. Ideally, I think they should be able to see it. So the timer starts now, 60 seconds.
Sir, option D, an RV systolic pressure greater than 50 millimeter of mercury is more consistent with restrictive cardiomyopathy than with constrictive.
Okay, so you're sure? You want me to lock it?
Yes, sir.
Option D. All right, they know it. I think for sure. Right? Let's see how sure you are. Lock D delta. Yes! They know it. Very well done. Very well played. And they have put up a score of 54 with this PIC Hawks. They have done it here, which was a virtual semi-final for them, and I think they've done it. So, very well played, PIC Hawks. My congratulations to you, commiserations to NICVD Kings. I think you've played very well throughout the season, but in the end, one team wins and the other team loses. It's not a loss. You're always gaining something. So, well done to both the teams. And PIC Hawks have actually, they have put up the highest total, and I think they've matched the highest total this season, and very nicely done. And I'm ecstatic as usual. I think I am now going to move towards our umpire, Professor Mohammad Ishaq Saab. Sir.
What a match. What a match. And hats off to PIC for, I think this is the maximum score so far in the tournament. And very well done. And all I can say is that the loser should not feel that they are losing it. They should take it as a challenge to learn more and expand their knowledge. Both the questions were day-to-day clinical practice. Resistant hypertension is quite common. Pericarditis, especially in our rural areas, is quite a common condition. Tuberculous pericarditis and non-tuberculous as well. So I think both the questions were very pertinent, and obviously there is PIC, and my congratulations to them. And my advice to the loser is not to lose the heart, but to take it as a challenge and do whatever they can to expand their knowledge and come up with better results in future. Thank you, Hamza, for your excellent moderation. I think we are heading towards the final round, isn't it?
Yes, sir, very right. So we just have the last match of Super Sixes, which is going to be consequential. It's an important game for both the teams, and we look forward to it. And then we have the final, which is going to be live at the CardioCon. And inshallah, we are all looking forward to it. A wonderful show put up once again. And we do have Professor Ambar Ashraf with us.
I will take your leave.
Sir.
I'll take leave. Actually, I am sort of traveling as well. But really, very sort of great excitement today. And the way you have conducted, as usual, excellent moderation. I think leave the rest of the comments to the other panelists and experts that are on board today. With this, thank you very much, and meet in the last and the final round of league. And thanks to Wilson Pharmaceutical for introducing this unique and novel concept of learning in cardiology. I've learned a lot. I'm sure everybody has learned. Thank you, and Allah Hafiz.
Thank you very much, sir.
Assalamu alaikum, sir.
Have a safe travel.
Assalamu alaikum, sir.
Madam.
Safe travel, sir.
Amber,
I'm Amber here. Assalamu alaikum, sir. It's so nice to hear from you every time. Thank you very much, sir. Safe travel.
The rest is yours. The mic is yours now. The floor is yours. Okay?
Thank you, sir. Thank you, sir. Allah Hafiz.
आप एक्यूपंक्चर करते हैं चाइनीज model?
Yes, madam. So, madam, I think Dr. Amber Ashraf is there. Please. Walaikum assalam, ma'am. It's great to have you on the show.
Thank you very much. मैंने थोड़ा लेट ज्वाइन किया. Sorry, मेरा कैट और उसमें busy थी. But really, I have enjoyed the way both the teams play. Salute to both the teams, their supervisors, and especially to Wilson's and to you. You conducted all these things very nicely. It's really a very wonderful learning experience, not only for the PGs, for us as well, because there are so many minute concepts in our everyday clinical practice. We are not touching them in such a deep way, but in these small MCQs, most of the things, even we people are revising it, our concepts are day by day becoming more clear. And for PGs, it's really a blessing. And salute to all the seniors who have contributed in these quiz to making the MCQs, and the Wilson Pharma, as well as to you. You are becoming our hero now, right? We are going to have a channel of Pakistan Cardiac Society, and you will lead for that. MashaAllah, you did so nice moderation. Here, I just want to share one important thing for the PGs. Don't lose hope and heart. NICVG team, you play very well. It's always a platform where we learn, and we must learn in the life how to improve ourselves once we are unable to achieve that particular target or goal, because these things are really motivational, and next time you people will come with more energy, hope, and more preparation. No doubt your preparation was up to the mark. That's why I told to my KTH team, although I was not happy with them, but anyhow, and all the praises and all the congratulations to PIC team. Heartiest congratulations, keep it up, and inshallah in the upcoming CardioCon, we are going to look forward for a wonderful sessions as well. Thank you very much for listening me and giving me this opportunity. Thanks a lot to Hamza and the rest of the team. Thank you.
Thank you very much. It's always a pleasure, ma'am, to have you and listen to your comments. I think it's important for our trainees, our residents, some very important things explained very nicely, that it's not about losing, it's not even about winning, it's about improving. It's a continuous process. We win some, we lose some, but we have to keep trying all our lives to achieve things, and we keep achieving all our lives. So once again, I really thank you for your presence, and with this I move to our the panel. I think we do have Professor Abdul Hamid Siddiqui Saab. Sir, are you there? I think for some odd reason he's showing up, but we cannot. Okay, he's back. Sir.
Is it? Oh yes, I think there is some connection problem anyway.
Right, sir.
Congratulations to PSC team. Very good competition, and everybody has enjoyed it. And thanks to the organizers, and particularly the way you conduct the this competition is really remarkable. So congratulations to all the winners, and good luck for the future for the next team. Thank you very much.
Thank you very much, sir. It's always great to have you. And with this, we now come to the end, and we know the outcome one team loses, the other team wins, but I think both the teams have done so well. We know that PIC Hawks have actually won this match and they've moved on to the next one, and we're very close to the final. But I think NICVD Kings, they really played like kings in this season, and what a wonderful team they were, and they still are, and all the teams are doing wonderfully well, and it's all about learning. We are all learning. It's learning for us on the go at the moment, and this is what it's all about. And I would like to congratulate Pakistan Cardiac Society for supporting this, and Wilson's Pharmaceutical for actually putting this up in this manner. And what a show it is, and what a performance it has been by everyone. With this, I'm now going to sign off, now that we have come to the end, and I'll see you in the next match, which is going to be another crucial match. And till then, it is going to be Allah Hafiz from my side. Take care of yourself.